let's talk about hypernatremia just for a few minutes. It affects people of all ages, but it's one of the more common electrolyte disorders seen in children and older adults. It's defined as a serum sodium level of more than 145 milliequivalents per liter. And it's usually caused by a fluid volume deficit, excessive sodium intake, or chronic renal disease or other disorder. The pathogenesis of it is water intake and water loss are generally balanced, but there is a disruption in water homeostasis, and that results in hypernatremia. So when water loss exceeds water intake, the serum osmolality rises and thirst is stimulated. Water balance is achieved as water intake increases, but the thirst receptors are stimulated when this rise is in the normal range of about 290 to 295. But destruction of the thirst centers in the hypothalamus result from whether it's neoplasm or trauma, vascular abnormality, that leads to inadequate thirst response and then hypernatremia. In older adults, the physiologic aging changes may increase susceptibility to electrolyte changes, but anyone unable to adequately express thirst, such as infants and those with decreased sensorium, are at risk for hypernatremia. So how do these people, our patients, present? Main clinical feature is central nervous system disturbance resulting from that dehydration and shrinkage of brain cells. They might have had a recent history of fever, vomiting, diarrhea, polyuria, heat exposure, or even recent surgery. All of those are significant to investigate. Ask about any meds or med changes, fluid intake and output in the last 24 hours, IV fluids and tube feedings. The patient might complain also of weakness, thirst, lightheadedness, or they might not have any symptoms. But usually over 150 milliequivalents per liter of sodium, you're going to see agitation, irritability, confusion, personality changes as early signs. But then, unfortunately, late signs, coma, seizure, and even muscle weakness can be a later sign of elevated sodium. Decreased urine output, except with diabetes insipidus. So the physical exam, we're really doing a comprehensive exam. We're trying to determine the underlying cause of the hypernatremia for our patient. Diagnostically, I'd like to refer you to page 1113. We've got to make sure that their glucose, what their glucose level is, their electrolytes, otherwise, calcium, urea, BUN, the blood urea nitrogen, and the creatinine, CBC with diff, urine sodium, osmolality, and specific gravity. You know, I'm looking at that specific gravity in that urine to see how hydrated my patient is or overhydrated. And then CT, MRI if you have a exam or a decision to try to determine that underlying cause. Differential diagnoses on page 113 give us a clue to some of the causes of hypernatremia, and they're quite extensive. So the first three are water depletion with insufficient water intake, excessive sweating and increased sensible water loss, and then diarrheal conditions. So you can see that those are things that happen quite commonly. Management, the primary goal is to replace that water loss and restore extracellular fluid volume so that we can bring the sodium levels to normal. Most mild to moderate hypernatremia can be managed outpatient, and the standard of care really is, or treatment is, oral water replacement. So the patient has to have the ability and also assistance. Any severe hypernatremia needs to be treated in the hospital. Complications, if it's not corrected, cerebrovascular damage occurs, and you can even see hypovolemic shock. We're always thinking about in congestive heart and heart patients, they can develop congestive heart failure because fluid is replaced too fast. Patient and family education includes normal daily intake should be between 1,500 to 2,000 milliliters of fluid daily. Maintain proper fluid balance. Elderly people particularly have to watch hot weather, and if they get fevers, those can deplete their hydration very quickly. And then we as providers must be aware of the side effects of meds that it can increase sodium. Thank you.